Hello, everyone. I am Ana Rodriguez. I'm your host for today's Brain Matters webinar, which today is presented by Drs. Elmer, Hirsch, and May. Before we start with that, and while we are waiting for any latecomers to get on board, I want to remind you all about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring and any other news coming from our company. You can sign up anytime on our website. And if you have an event or news item related to neuromonitoring that you would like us to share with everybody else, please send it to us at info.us@micromedgroup.com. And now on with the webinar. Today, we are honored to have the co-PIs of PRECICECAP, Dr. Elmer, Hirsch, and May, as I said, and they're going to speak on the topic of precision care after cardiac arrest. Dr. Elmer is an emergency physician and neurointensivist, as well as associate professor of emergency medicine and critical care medicine and neurology at the University of Pittsburgh. Dr. Hirsch is a neurointensivist, associate professor of neurology and neurological sciences, and division chief of neurocritical care at Stanford University. And Dr. May practices pulmonary critical care and neurocritical care at Maine Medical Center and is an assistant professor of medicine and faculty scientist at Tufts University. Before I pass the floor to them, I would like to remind you that you can type any questions during the talk using the Q&A tool within Zoom. And all of your questions will be addressed in the Q&A after the presentation. So now I would like to ask the speakers to start sharing the screen so that we can proceed with the webinar.
Great, thanks so much. And thanks for that introduction. All right, so as Anna said, we are the PRECICECAP team, or part of the PRECICECAP team, and we'll be talking about precision care in cardiac arrest in general, and also in relation to the study that we're working on. So I'll be starting. I'm a co-I on the team, and I'll be talking about limitations in current neuroprognostication. Dr. Hirsch will be speaking about post-arrest prognostication and precision medicine, and Dr. Emma will be talking about precision medicine after cardiac arrest. So for my section, I'd like to talk a little bit kind of from a very high level view about our current prognostication practices and what limitations those might have. I'd like to touch on prognostication versus prediction of illness, because those are two very different things. And then briefly talk about the integration of machine learning aids into clinical care and trials. So a few disclosures. Obviously, I'm part of the PRECICECAP team, as I said. I'm also the U.S. director of INDICAR, and I have a grant on the effect of virality in cardiac arrest care through GMS. So this is what we typically do right now for prognostication and neuroprognostication after cardiac arrest. And this comes from one of our recent guidelines. And it's a nice pictorial representation of what we do. I really like it because it separates our care into different times. And the first 2 days, we literally just take care of the patient. So do what you're going to do. In days 3 to 5, we gather data. We also turn off sedation. So excluding confounders, particularly sedation, is an important thing to think about. And then we wait. And after 3 to 5 days, with the exception of very specific circumstances, we use multimodal prognostication whenever possible. And I think Dr. Hirsch will talk about that in more detail. So over here on the right side, this is the same concept, just in text. And this is from the TTM2 study, where they did a very excellent job at neuroprognostication. So if we have all this data, the question is really, what does multimodal prognostication mean? And essentially, we have a lot of data, and we can take that and put it together and make an estimate, which kind of lends itself to building a model. Where you can actually get a point estimate and a confidence interval about how patients are going to do. And I'll say this has been done. It's been done quite a bit. So Tufts has this prediction model registry, and they have one section specific to cardiac arrest. And over the past 40 years, there's been over 80 prediction models with patients with cardiac arrest. There's been over 60 validations of those models. And yet we don't really use any of them. So when somebody comes to my ICU on admission, I want to know how sick they are, but I don't necessarily talk to the family about what the numbers are. And I certainly don't use any information to exclude patients from the ICU or say that a patient wouldn't be admitted because they have a poor prognosis. So you can see here the discrimination of the validation studies and the novel models. The validation is not as good as the novel models, which is pretty common in prediction models. And interestingly, these are the 10 top factors in all of these models into what predicts outcome. So a lot of this we can't change, right? So there's the initial rhythm, the age, things associated with the arrest, some laboratory data, the neurologic exam. Obviously, we want these prediction models are meant to be early prediction models, but it sort of implies that what we do in the ICU doesn't really matter. So regardless of what we do, these factors are static and we can't really change them. So how do we incorporate our treatments into how the patients are going to do? So this brings us to the thought and the strong thought that all models are wrong, but some are useful. So how can we take the data that we have and make a more useful model? And this is where the early prediction versus early severity of illness is important. So right now we are talking about early prognostication versus delayed prognostication. So we know based on the guidelines, we should look at delayed prognostication. But when a patient's admitted, what I really want to know is what are the patient's risk of a certain outcome, and how can I change that outcome over the course of their ICU admission? So I want to know about their early severity of illness, specific to different outcomes. And then I also want to do delayed prognostication. So this is the paradigm that we would like to be working in. And to take that a step further, so in the hypothetical world that we have a model that's accurate, that tells us about severity of illness, we can then test targeted treatments specific to those patients with specific risks to sort of change the needle of what that outcome will be. And then we can implement that into clinical care. And as this starts moving, eventually we will improve care overall and make our initial models inaccurate. So this is kind of the holy grail of what we would like to do in cardiac arrest. And obviously this would keep us all very interested and writing grants and keeping us busy, but also continuously improving patient care, even for the very sick patients. And that brings us to the Icecap trial. So I'm sure all of you know about the Icecap trial that's ongoing right now, testing doses of temperature management in different patients. It separates patients into shockable and non-shockable rhythms right now, which is very good. But this additional ancillary study aims to separate patients out into different groups. And what these groups will be is currently unknown. The goal, once we have these groups, not part of this trial, but for future directions, would be to stratify our treatments. And this has not necessarily been done, but this is sort of proof of concept of how patients can be grouped into different categories. So this is mostly the work of Dr. Elmer at Pittsburgh, and you'll see these slides over and over again, these charts. And here, a retrospective cohort was used to group patients into different categories based on their clinical factors. And then looking at their treatments or their data as they move through their ICU stay, we see very distinct differences in them. So here's the suppression ratio of these 5 groups over time. And you can see here that some groups stay high with their suppression ratio, some decrease quite a bit, some go down linearly, and some stay low. And these patients have very different outcomes associated with their group and what their suppression ratio behaves like. That brings us to precision medicine. The NIH defines or describes precision medicine as a stratification of patients using large-scale data to go beyond the sign and symptom approach. And they spend a lot of time discussing clinical factors, lifestyle, genetic, and biomarkers as things that can be incorporated into precision medicine. The cardiac arrest patients, like we know, are very complicated. So there's a lot more that goes into them, and we're really working in real time to sort of assess what their needs are at any given point. So here you have the patient characteristics and the arrest characteristics, but really everything else happens in the ICU, and we have to make sure that we are doing a good job at collecting the data so we have the most accurate data, and then using it to implement different treatments. So there's a lot of data available in the ICU, especially in neuro ICUs and cardiac ICUs. And the goal is to capture this in a reasonable way where we're able to effectively use it, again, in real time. So there's the EEG, heart rate waveforms, blood pressure variability, pulse ox, pupillimetry, sedation dosing, imaging biomarkers, and this is just some of the data that's available to us. The data itself is helpful, but a lot has to happen to the data before we're able to use it. And Dr. Elmer will talk about this as well. So the data has to be acquired in a standardized way. We have to transfer it and store it together. We have to assess for data quality, look at artifact rejection, has to be annotated, and so on and so on. But it's a lot of work to get all this data in a usable format. But once we can do that, the goal is to sort of see what's under the surface. And we believe that there's a lot under the surface to learn from these patients. So once we have the data and it's in a reasonable format, what can we do with it? So artificial learning has to do with machine learning and deep learning, are both types of artificial intelligence. And there's a bunch of different ways to do it. So a lot of ways to get from point A to point B, and they all have some benefits and some drawbacks. And we won't go into all of these together, but machine learning by itself is very nondescript, and you have to spend a lot of time thinking about which type of machine learning is best suited for an individual data set. So here's an example of this. So again, Dr. Elmer's retrospective patients grouped into different categories. And these categories, when we look back at how they were treated, there are some differences that probably matter within some groups. So some groups did better with a different MAP goal. Some groups did better with a different temperature target. But if we take these collectively, it's unlikely we're going to find this difference across the entire group. Here's another example. So this is the CREST model. It was developed within the INCAR data set and validated as well. So it looks at your risk of circulatory etiology death specifically, which is very different than patients who die of a neurologic death. So there's increasing risk of circulatory etiology death with increasing number of predictors we have here. And although it hasn't been tested in a clinical trial, we'll sometimes pull this out in our clinical care of patients to sort of twist the arm of a cardiologist or another intensivist that really is worried about the neurologic status of the patient, but we can tell them that the risk of circulatory etiology death is high in this patient, and therefore they might need more aggressive care, like going to the cath lab or having a balloon pump or having additional support in that way. That brings us to more discovering, and again, this is very high level. We'll get into more detail later in the hour, but discovering the unexpected is more important than confirming the unknown. And that's the goal that we have moving forward with these patients. So we just go over what we talked about. We talked about current prognostication and limitations, prognostication versus predictions of illness, and then integration of these machine learning aids into clinical care and potentially trials. So up next, you'll be hearing from Dr. Hirsch, and she'll be talking about post-arrest prognostication and precision medicine.
All right, thank you so much. Let me get my screen up here. All right, somebody holler at me or text me if this does not look right for you all, but I will just go ahead and dive in. Teresa, can you give me a thumbs up maybe? Okay, perfect. All right, thank you. As Dr. May said, I'm Karen Hirsch. I'm one of the co-PIs of PRECICECAP, and really just want to acknowledge what she said as well, that it really is a team effort. Here are some of my disclosures. And let me just dive in right now and start talking a little bit more nuanced about prognostication after adult cardiac arrest. I know that we have some friendly faces on the call that are pediatric intensivists and neonatal intensivists. And so we're really talking about adults, but obviously want to think about this across the spectrum of the lifespan. And so when we think about taking care of adult cardiac arrest patients, it's really becoming quite clear from multiple studies and papers, including work by Dr. Elmer and Dr. May, that inaccurate prognostication, which leads to withdrawal of life-sustaining therapy, is actually sacrificing people that can go on to potentially have a good outcome. And one thing I think that has been most insightful for us working with the Icecap team and just other leaders in cardiac arrest around the country is learning that even at places that are so-called good places for cardiac arrest care, we are still seen as a collective society, as a group of people interested in cardiac arrest. We are still seeing people withdraw care very, very early on patients, despite all of the literature and admonitions that we need to wait. And so we know that there's many, many avoidable deaths every year, and we really don't know how many of those we're actually missing. It's probably many, many more. As you heard from Dr. May, prognostication is not a bad word. I think that we've drilled it into our team so much that we don't prognosticate early, that they'll write in their initial notes for traumatic brain injury and cardiac arrest, things like, we will not prognosticate at this point, too early to prognosticate. But in reality, as clinicians taking care of critically ill patients, we're prognosticating at every step of the way. What we're not doing is rendering an ultimate judgment about long-term outcomes early on in the course, and that is very important. But prognostication happens constantly. It happens continuously in the ICU and in the emergency department. And it's really important because, as you see here, I underlined point number 2, which is that prognostication is really used to guide interventions. We're not going to apply therapies to patients who aren't going to benefit from them, but really we want to be more nuanced about identifying which patients are going to benefit from which therapies. And that is the overarching goal of prognostication. I wear a slightly different hat at work sometimes, which is working with the bioethics team and doing some ethics projects and research as well. And it's very interesting, especially in the last 2 years of COVID, when we talk about resource allocation and ethical principles of justice and allocation of scarce resources. When we take care of individual patients in front of us, we are never supposed to evaluate allocation of resources across others, but obviously we have an obligation to do things that are going to help people and not do interventions that aren't going to help people. So thinking about how we apply our very limited resources, especially resources that are becoming more and more common after cardiac arrest, like ECMO and mechanical circulatory support, and really identify patients that have a good chance of responding to therapies and not giving those interventions to patients who are not going to respond. So what is the fundamental premise here? I will talk in a bit about our current prognostication, but I will say our fundamental approach and what we hope you take away from this is that not all post-arrest patients are identical. And so we love if-then statements in medicine. And so if patients are different, then responses to therapies is also likely very different. And prognostic outlook for those patients is also very different. And so it's very difficult to apply single tools, single rules, single models to the patient in front of you because you don't know where that individual patient fits in the broad scheme of heterogeneity. Our aha moment came several years ago. Obviously, it takes many years to go from conception to funding to actually getting data and a grant. And many, many years ago, this started because we were thinking about patients with acute stroke and identifying them for acute stroke therapy and looking at diffusion and perfusion mismatch. And somebody said, wouldn't it be great if we had diffusion-perfusion mismatch for the brain after cardiac arrest? And that led to this whole concept of identifying patients with precision therapy for for interventions after cardiac arrest. So what is the current state of neuroprognostication? Dr. May showed you the ERC tool, which is the European Resuscitation Consortium. Here's the AHA one from the 2020 guidelines. Essentially, they have some very slight differences, but they're essentially saying the same thing. That is, use multimodal data from different modalities, look at serum biomarkers, imaging, electrophysiology, your exam, etc. Do TTM. We won't get into the mess of temperature targets, but let's just say do TTM and wait. Take time, don't jump to conclusions, limit sedation, and put all of these puzzle pieces together to think about rendering a neuroprognosis for the individual patient in front of you. But there's many, many challenges and limitations. And if we look at what goes into the data, you'll actually see that there's a very high risk of bias associated with all of this work. That is no criticism. We're all doing the best we can. But we continue to have very significant concerns and limitations on the data that has gone into informing those prognostic studies. I'll highlight the orange box on the left, which says that most of these studies don't account for important things like medications, hypothermia, and systemic organ dysfunction. I will also call your attention to a nice paper, a scientific statement from the AHA from just a few years ago that puts out standards for neuroprognostication studies and really highlights the way that these future studies should be done and essentially addresses many of the things that you see in this slide, which is making sure that all of these things are standardized, that we're looking at standard outcomes, the way we care for patients, that we're blinded, withdrawal of care is not factoring into this, et cetera. And you'll quickly see that that's very challenging to do. So let me shift gears a bit away from prognostication and think about how we take care of patients in the ICU. The next two slides are here to make a point to you all. And the point is that the damage is not necessarily done when the patient hits the doors of the emergency department. I think there's a lot of nihilism about these patients, but there's actually really nice data from imaging and electrophysiology work that shows that the ongoing injury to the brain continues over the next 2 to 3 days, essentially, after the cardiac arrest. This is from our group several years back, showing that the imaging findings after cardiac arrest actually evolve. Interestingly, if you do an MRI in a patient in the first 24 hours after cardiac arrest, you won't see restricted diffusion and you won't see injury in patients that still have a significant injury. Very different than acute ischemic stroke. And the pathophysiologic mechanisms of this are still poorly understood. But certainly by day 2, 3, 4, and 5, these imaging changes become much more apparent. Same thing for electrophysiology, as I said. Here's that same slide from Dr. Elmer's work and a different one looking at quantitative EEG over time, basically showing that these changes in electrophysiology happen over hours to days post-arrest. And therefore, that tells us that there is a window of opportunity for us to intervene. It also tells us that we need to be very cognizant of the timing of the diagnostic studies that are being used for neuroprognostication and when they're being done in relation to both the cardiac arrest and everything else that's going on with the patient, including medication, sedation, and systemic organ dysfunction. And so this slide I use in many of my talks. It's from the Allstate commercials where they say mayhem is everywhere. And I really do feel like taking care of a cardiac arrest patient in the ICU is a bit like looking out at every turn for what mayhem is going to hit next. These patients are incredibly sick, as you all know. They have multi-organ failure, and some of it is just staving off the mayhem of the nihilism. And so the threats are multiple. These are really focused just on the neurologic threats that happen in the days, hours, and days after cardiac arrest and thinking about how we address them. But the overarching concerns about self-fulfilling prophecies and nihilism and withdrawal of care are also very, very real. Even at my own center, where we are very actively involved in the care of all post-arrest patients, it sometimes feels like we're fighting a uphill battle to convince our colleagues that we really need to keep going and really be very active and vigilant about managing all of these other things that happen to these patients in the hours and days after cardiac arrest. So shifting over into the shiny appeal of big data, I was inspired by Dr. May's slides to include some quotes. I think that anywhere and everywhere around us these days, people talk about artificial intelligence and machine learning. I will go out on a limb to say many people who are throwing around the terms don't actually understand what they mean, but they know that they're shiny and they get attention and it sounds great. But we really need to be very aware of the flaws and biases associated with these mechanisms and approaches. Dr. Elmer will talk more about them. We use them and we're going to continue to use them, and they have their place. But we really need to be careful in thinking about how we apply them. I like this quote where it talks about, it's from a paper on big data and using big data in medicine to actually do precision care. And it talks about the exact challenges that we talk about in cardiac arrest, which is it's very difficult for us to identify phenotypes and be, granular and specific about how we care for patients. But this paper actually goes on to say that we have to be careful and issues many of the warnings that I have just said when we think about how to use these methods and approaches to analyzing data in these cardiac arrest patients. Last but not least, I'll say the other fundamental premise of neuroprognostication and what we're trying to look at in PRECICECAP is the idea that it's not just individualized management of the brain injury, but that the heart and the lungs and all of this multi-organ function is intrinsically linked together, and we can't ignore it. And anytime you look at a study that just looks at EEG or just looks at MRI and completely ignores everything else that's going on below the neck, that is a huge problem, because we have we can't just take care of the brain in isolation. We have to take care of the brain and the heart and the lungs and all of the other organs that are critically intertwined and the dysfunction that goes with that. And that is the biggest challenge, I think, in caring for these patients, and really the biggest opportunity in harnessing this huge amount of critical care data that we have and really using it to figure out how we're going to apply precision care to these patients. So without further ado, let me turn it over to my colleague, Dr. Elmer, to talk about our actual study, PRECICECAP.
Thank you, Dr. Hirsch. So now I will ask you to confirm you can see my slides okay? Awesome. Thank you so much. It's my pleasure now to sort of bring those first two excellent talks forward into, so what are we going to do about it? Before I get started, my disclosures are primarily research grant support for work that is related to the PRECICECAP project, either directly because it is the PRECICECAP project or indirectly. To summarize some of the threats to our current standard of care and our current conceptual framework of prognostication after cardiac arrest, and really more generally after any neurocritical illness or critical illness in general, that Dr. Hirsch and Dr. May nicely outlined. The state of the art right now is that prognostication and the prognostic models that Dr. May outlined for us focus on a binary decision to continue or to withdraw life-sustaining therapies, recognizing that when life-sustaining therapies are withdrawn in the ICU, it nearly invariably leads to a patient's death. So prognostication then is high stakes. It could not be higher stakes. We know that we don't do a great job of this. When we looked at data from hospitals that participated in the Resuscitation Outcomes Consortium, a multi-center research network that focused in part on post-arrest care, we found that the most common day at these expert research participating hospitals for life-sustaining therapies to be withdrawn for perceived poor neurologic prognosis was the day that the patient was admitted. We also know, and you all on this call know, that the guidelines say we shouldn't be doing this until day 3, and that concerningly, nearly half of patients who awaken from coma after resuscitation from cardiac arrest will do so after day 3. Drs. Hirsch and May also emphasized that current models for outcome prediction after cardiac arrest are fundamentally flawed. One of the major flaws in this is the inputs to those models. So we love looking at initial rhythm, at patient age, at the interval from collapse to CPR or CPR to return of spontaneous circulation. We love looking at witnessed arrest, presenting lab data. And we like this primarily because it's easy. Anyone with an electronic health record can extract these sorts of data. They're time invariant, they're simple, they're neatly packaged. They've been defined by the Utstein criteria for years now. So they're very pragmatic if you need to publish a paper on a prognostic model to use as inputs. But they don't capture most of what we care about clinically in the ICU when treating the patient in front of us. As was mentioned already, the other fundamental flaw in our current approach to prognostication is that even when we put in the ideal set of predictors, all the EEG and the medications and the vital signs and those time invariant data from the last slide, and we feed it into the model, and we try to find the best possible association with outcome, most patients who die are in the bucket where life-sustaining therapies were withdrawn. And our models fundamentally cannot reconstruct the counterfactual outcome for those patients of what might have happened were life-sustaining therapies to be continued. We and others have done risk-adjusted analyses that suggest that many of these patients might otherwise recover. And if you assume that some of those patients might recover, then you commit yourself instead to finding spurious correlations, where the model will find predictors, it will associate them with poor outcome, because that's the observed outcome, not the counterfactual outcome of what would have happened if we hadn't given up too soon. So all of this necessitates a fundamentally different approach to prognostication. There is no way in which we can reliably predict probability of recovery. Even if you imagine a magical world where life-sustaining therapies were never withdrawn, acute and post-acute care is still resource limited, and it's not plausible that we'll be able to provide all the interventions to every patient indefinitely to try to observe their outcome under the best case scenario, where they go to the nursing facility that has one-to-one nurse-to-patient care and all the resources to manage that post-acute patient on their road to recovery. So then the question is, what else can we do? And this is a slide that people born within 10 years of me will recognize. This is Zelda, where there's a little life meter, and that's what we're doing now. We're trying to figure out how many hearts the patient has. And I and we would posit that instead we need an alternative approach, and one that aims to optimize the care we deliver to the individual patient to maximize their recovery potential. So when we talk about optimizing individual care, we're talking about precision medicine. And the goal then is to discover markers that are valid in real time that indicate clinical need or indicate treatment responsiveness. And in the ICU, I would argue that it's similarly implausible that things like presenting rhythm or no flow time are all that we need to know about patients to figure out their individual need or treatment responsiveness today, and then reassess it tomorrow, and then reassess it the day after to optimize care on an ongoing and a dynamic basis. So there's been a growing body of research in this area. This is two of many studies that have looked at the association of illness severity measured one of many ways, and an interaction with target temperature, leveraging, for example, natural practice variation since the first TTM study came out in patients who are allocated to 33 or 36 degrees as local standard of care. The graph you see on the right of your screen there is from a nationwide cohort from Japan. The x-axis is an overall measure of post-arrest illness severity, looking at things like pH and other markers of ischemia. And on the y-axis here is the association of treatment at 33 degrees versus 36 degrees with outcome. And you find, like all critical illness, that there's a U-shaped association. There are patients that are too well to benefit, There are patients who are too sick to benefit. And then there's a sweet spot here in the middle where patients do respond. If you look at the overall cohort, importantly, there's no association of target temperature in this cohort with outcome. It's only when you start to drill down on risk stratifying the patients that the associations emerge. So the Precision Care in Cardiac Arrest Icecap ancillary study, or PRECICECAP, then fundamentally hypothesizes that not all post-arrest patients are identical, that this variability can be quantified, and that individualized care is possible. So we are fortunate enough to be embedded in the Icecap multi-center trial. As Dr. May mentioned already, Icecap is randomizing patients to different durations of hypothermia to 33 degrees. It's stratified based on presenting rhythm, but not on other patient characteristics. And it's exploring the association of hypothermia duration, or the effect, I should say, since it's randomized, of hypothermia duration on 90-day functional recovery. Within the Icecap study, there are clinical standardization guidelines focused specifically on post-arrest prognostication and withdrawal. Withdrawal for perceived poor neurologic prognosis or really any other reason is strongly discouraged before day 5. Multimodality neurologic and other prognostic tests are required, and patients next of kin who consent to Icecap are told upfront that the anticipation will be that there will be at least 5-day trial of critical care to look for signs of recovery. So let's try to be a little bit concrete on what I'm talking about and imagine a few Icecap patients that we've enrolled. I've enrolled patients who have absent brainstem reflexes, except that they're overbreathing the ventilator. They get cooled to 33 degrees. They get randomized to Icecap. They have head imaging that then shows diffuse cerebral edema with little but not absent intracranial flow, an EEG that is isoelectric and stays so for the first few days. I would posit that an extra 6, 8, 12, or 24 hours of hypothermia to 33 degrees probably won't move the needle on that patient's outcome. That when you have diffuse cerebral edema and are already losing cortical blood flow, hypothermia is not going to be the silver bullet. We've randomized patients who have witnessed VFib and who present withdrawing from pain with reactive and variable EEGs that have a continuous background. And it may be that hypothermia doesn't really move the needles for those patients with very, very light brain injury either. They're too well to benefit. And one other patient, to emphasize Dr. Hirsch's point that it's not all about the brain, was a patient who had bilateral pulmonary emboli, and after 48 hours, despite thrombolysis and anticoagulation, had a mean arterial blood pressure in the 30s on all the vasopressors we had to offer. Hypothermia is probably not the answer for that one either. So then the question is, how do we approach these patients to capture the full breadth of heterogeneity that might define their signatures of illness or hypothermia responsiveness? Well, one thing we need is lots of data. So in PRECICECAP, we collect the bedside waveform cardiopulmonary data. We collect their imaging, MRI and CT scan. We collect continuous EEG. We collect their medication data. We collect their serum biomarker data. When sites are using other neuromonitoring modalities, we collect that. Those heterogeneous and often continuous inputs we're putting in an autoencoder neural network. That's the tool we're using, and I don't want to focus on that too much. But as a tool, what these networks seek to do is to find the simplest representations of those data, which can be effectively used to reconstruct the data on the back end. So what do you need to know about the data, the patterns of these data, the relationships between these data, in order to capture most, if not all, of the variability explained by the inputs? And what you end up with is a fairly sparse representation of those data that make up this so-called encoded data within the latent space. And again, I don't want to belabor the math of the model. Imagine that you end up with 1 or 2 or 5 perhaps nodes here in this latent space. And those nodes become our phenotype. So a little bit more then about how we go about this. It's important in multi-centered work to have standard approaches for data collection and data storage. So our critical care data and our EEG are captured at the bedside for every patient with the CNS monitor that allows time-stamped continuous data acquisition. Medication and imaging data come directly out of the electronic health record and are uploaded to the cloud. And then we're collecting lower resolution case report forms as well through the Siren research infrastructure. Our high resolution data are getting uploaded into secure cloud storage, where they enter into the pipeline of data processing, including review for data quality and completion, artifact rejection, feature creation, and so on. Drilling down on that pipeline a little bit, we've been fortunate to partner with Dick Moberg and his team of analysts and coders to develop a standardized and reproducible approach to the process of data harmonization, annotation, and feature creation, such that if you try to feed the same inputs into this pipeline and run the same models, you'd get the same outputs. And that's critically important. Neural networks, like many machine learning approaches, are quite fragile, and small, seemingly arbitrary perturbations in the inputs can lead to wild swings in the output. So if I annotate a valid segment a few seconds different than Dr. May or Dr. Hirsch, there's some trivial and clinically insignificant variation in the model inputs. You don't want the model outputs to change. That's a threat to the rigor and the reproducibility of the work. And by standardizing and, when possible, automating this pipeline, we seek to overcome that limitation. As we get these clean data and feed them into our model, this is our primary study hypothesis that we seek to test. This is a dose response curve of hypothermia duration here on the x-axis, which is randomly allocated, and a slight mathematical modification of modified Rankin score at 90 days to make it nicer in the models. And so, as we have discussed already, we hypothesize a couple things. One is that there will be subgroups that have distinct hypothermia duration response curves. So we've made one up here. We hypothesize that patients who have refractory shock despite optimal medical therapy or catastrophic initial cerebral edema will have no functional recovery at 90 days, regardless of hypothermia duration, that curve will be a flat line. Similarly, we hypothesize that there will be patients who have intermediate severity illness for whom a longer duration of hypothermia will initially be better, potentially with a drop-off. And so the key characteristic in what our analysis aims to find is this inflection point here in that curve, where longer hypothermia goes from being helpful to potentially harmful or at least neutral. Because we're interested in continually updating and optimizing care at the bedside, we'll only consider predictors up to the point of rewarming. So the question that we seek to inform then for the clinician at the bedside is at hour 6, at hour 8, at hour 12, at hour 24, if I continue hypothermia in this patient for another 6, 12, or 24 hours, is it likely that that will move the needle on that patient's functional recovery at 90 days? We are in month 3 of enrollment now. If there are folks on the call who are enrolling in Icecap who are not part of PRECICECAP, we welcome the opportunity to talk with you about joining. And with that, I will stop sharing my screen and turn it back over to Anna and the team to take questions.
Thank you very much for the presentation. It was great. I remind everybody, if you'd like to present any questions to the speakers, please enter them in the Q&A tool in Zoom so that we can pass them on to them. Again, the presentation was great. I am sure the plenty of sites out there are going to be eagerly waiting for the results of the study. I had a very simple question. Once the results will be out, I'm sure the study will be successful. You'll be able to design, use the data to inform the models and improve upon what you have now. How do you see a medium-sized ICU making use of the results from your study and your models, implementing them in a in their day-to-day clinical care of their patients?
Do you want to take this, Jonathan?
Sure. So I think number one, PRECICECAP is not going to answer the question. PRECICECAP is observational and it's hypothesis generating. So before that small or even large ICU uses our findings to change care, we need to prove that they work. And so if PRECICECAP is successful, the follow-up work would need to be a trial that actually randomized patients to personalized or titrated care versus usual standard of care, which in the US is typically 24 hours of hypothermia. So there is additional validation work that will be necessary. This is a proof of concept. What you're alluding to, I think, assuming that this is validated, speaks of the challenges with integrating models with clinicians and their bedside care. So our hope is that the predictions that we make will be interpretable. And we're partnering with experts to work on interpretability of models in particular. So clinicians want to know, why is this model telling me what it's telling me? What is it about this patient, and do I believe it? The results also need to be simple, and they need to be served up in a time frame that's useful. So for this to be used in clinical practice, the data would need to interface with the model in real time. So I would imagine, for example, a CNS monitor at the bedside with connectivity and an algorithm on a cloud that's a learning model. The data at the bedside would beam to the cloud, run through the model, and the results would be served back up to the clinician saying, what is my prediction and why, and how confident am I? But as you allude to correctly, on implementing this in practice takes more than just a model, more than just the data collection, but also the real-time connectivity to serve the clinicians up the answers that they're looking for.
Right. And to follow up on what you just said, and remembering what Dr. May mentioned about using the data to improve the models until you have enough data to make them imperfect and go back to square one and improving them again. In that ideal scenario that you just described, would you see reusing that additional data to keep on improving upon the models, or would that be done in a more standard research setting where you use very standardized methods of collecting the data to answer the specific scientific questions that are needed to improve those models?
So there's probably two answers to your question. One is scientifically what's best. And scientifically what's best would be for a learning model over time. So as data accrue from additional patient observations, those are used to update the model over time. And the model continues to learn as care changes, as patient outcomes improve over time. I think the pragmatic question would be how the FDA wants to regulate algorithms. And when this work is done, whether or not the FDA will allow learning models. And that, I think, is a more complicated question that's probably outside of our direct areas of expertise, but right now, probably not allowable.
Right. And it's a very evolving field. So by the time the big scientific questions are answered enough to create the first model, the regulatory landscape might have changed. You also mentioned that if there are sites that are in Icecap and that would like to participate, to get in touch with you, what would be the best way for them to reach out? We have a related question in our Q&A.
Yeah, thank you. Just email us. We can put our emails in the chat right now. They're also available on the PRECICECAP website through the Siren Network. I was going to moderate the questions, if that's okay. Yeah.
Sure.
Okay, perfect. I was going to just take the next one that's in the chat. It says, how do you detect the inflection point without over-treating with hypothermia? I think this is a great question. I would say that's actually the fundamental question that the Icecap trial is trying to address. This question ties in to another question in the chat, which is also about how some hospitals are now aiming for normothermia based on TTM2. So these are somewhat all related topics and questions. And I will say that the Icecap investigators were given permission from the Data Safety and Monitoring Board to continue. Yes, the Icecap investigators were given permission to continue with the Icecap trial, even after the results of TTM2 came out. I'm not on the DSMB. I suspect there's many reasons for that. But one of them is the idea that perhaps this non-nuanced approach to temperature management, where everyone gets the same duration, is one of the reasons why the TTM trials are not finding a benefit. That's a hypothesis that is not necessarily based on data. But the Icecap trial is exactly trying to identify what you all are mentioning, which is that there is probably an inflection point at which point different durations are beneficial for different patients. And so that's what we're trying to figure out. We agree that conceptually that there is an inflection point, and that, as Dr. Elmer said, at some point, continuing temperature management is probably going to do harm to patients. The other thing I would say, again, wearing a very biased hat, and this is my opinion only, I'd love to hear from the other panelists, is that I think our results will still be meaningful for hospitals that are doing controlled normothermia or different temperature targets besides 33, because I suspect that we'll have vast amounts of data that will inform how we take care of these patients, almost regardless of temperature target. But again, that I think remains to be seen. So as Dr. Elmer was saying, the translation of this to bedside care is still many eons away, but something that we hope will inform practice, certainly in the next 5 to 10 years. Dr. Elmer, Dr. May, anything else to add to that?
So I'll agree with you. And I think, in the setting that the Icecap trial is neutral, or there's not an inflection point, I think our findings will still be interesting and will inform subsequent trials. If going back to the TTM2 study, so if temperature doesn't necessarily improve outcomes, it also didn't really cause harm. It depends on what arrhythmia you think might be harmful or not. But even in that setting, if there's no harm and there's no benefit, then why not test duration as a treatment? And there may be an inflection point there. Again, one of the limitations with a lot of the critical care trials that we do, the reason why the majority of them are negative, believe that we test patients on the whole, and we're not testing the right type of patients. So hopefully this methodology will be applied to other ICU settings, whether it's ARDS, sepsis. I think there has been other work in those fields, and this hopefully will build upon that.
I think we are caught up on the chat and the Q&A, but please keep the questions coming. I will take prerogative, if I may, to ask Dr. Elmer to expand a little bit on the comment you made at the end that we're only incorporating data that is obtained prior to temperature duration. Since we are including MRI and other things that happen later, maybe you could just comment a little more on the nuances of the two aims and how this different data is being incorporated.
Sure, and thanks for the opportunity. Obviously, the analytical plan is more complex and can be easily distilled down into 15 minutes. So we do aim to predict optimal treatment duration. That's one important aim, and to that end, a clinically relevant model can't gather data in the future and then look back on what you wish you had done, unless those data would be available in the future to the clinician in real time. We also aim to predict outcome. We're going to try to do that in a slightly more nuanced way than has been previously done, again, with access to the full available information, and hopefully also some qualitative work alongside our study, looking at what motivated the decision making. We hope to try to mitigate the risk of self-fulfilling prophecies and allow some less biased outcome predictions. And so those data, as Dr. Hirsch alluded to, will use all available clinical information that's gathered over the course of their acute resuscitation and early ICU stay, including MRI and SSEPs and other measures of brain injury and extra cerebral organ injury, both before, during, and after rewarming.
All right. I think that's it. We are approaching the top of the hour. I know this webinar will be cleaned up a bit and posted. I'll let Dr. Rodriguez wrap up, but I will say I know I can stay on for a few minutes after. Our emails are in the chat. If anyone's interested in talking science or PRECICECAP or both, we would love to hear from you. Thank you.
Thank you very much again for the presentation and the time you took to answer the questions. So again, thanks also to all of our participants that joined us today, and we hope to see you all for our next webinar. Thank you very much.
Thank you all for joining.